Hi, this is Peter Glenn Waichua, and this is my lecture on history taking and physical examination of the chest, prepared for Year Level 6 of the Ateneo de Manila University School of Medicine and Public Health. For this lecture, this is our overview. First, we will be moving through a review of anatomy and physiology, followed by history taking focused on some key symptoms including chest pain, dyspnea, cough, and hemoptysis. And finally, we will be going to the topic and the practice of physical examination of the posterior and anterior chest. An important exception to the scope of this material are the breasts. While the breasts are anatomically in the chest, they will not be emphasized in this material. The primary reference is Bates' Guide to Physical Examination and History Taking. And from Bates, we see several examples of reporting of the physical examination findings of the chest. In this example of an unremarkable write-up describing the normal chest and lungs, we see important components of the physical examination technique. The write-up reads, thorax is symmetric with good expansion, lungs resonant, breath sounds vesicular, no rales, wheezes, or rhonchi. Diaphragms descend 4 centimeters bilaterally. Compare that to this write-up suggestive of chronic obstructive pulmonary disease. And it reads, thorax symmetric with moderate kyphosis and increased anteroposterior diameter, decreased expansion. Lungs are hyperresonant. Breath sounds distant with delayed expiratory phase and scattered expiratory wheezes. Fremitus decreased. No bronchophony, egophony, or whispered pectoriloquy. Diaphragms descend 2 centimeters bilaterally. Note that these write-ups reflect a structure and approach to the physical examination of the chest. One of the goals of this material is for you to be familiar with reporting the findings of the physical examination of the chest following the structure prescribed by Bates. And so you are expected to produce a report, a write-up, structured much like these. And so we move on to the first part of this material, the review of anatomy and physiology. In this illustration, we see the different structures of the chest. Note that the airway is not confined strictly to the chest. The airway starts from the nose and includes your nasal turbinates, your nasopharynx, your oropharynx, your hypopharynx, and the pharynx communicates with your larynx and the esophagus, which is now part of the anatomic chest. In the chest, we don't only see the apparatus or the organs for breathing. We see a very important organ for overall homeostasis, the heart. The heart, which moves blood and nutrients and fluid all throughout the body. In fact, the heart is at the center of the chest, although skewed slightly to the left. And on each side, we have the key organs of respiration, your lungs. So, your lungs are actually invested in a very tough um, fibrous pleura, which is insensate, which means that the pleura do not necessarily have pain receptors, but they feel some stretch. The same applies to the pericardium. The fact that these are tough membranes, these are tough tissues, means that they can hold in fluids, they can hold in water and other liquids confined in particular spaces. Now, the chest is well protected with a bony rib cage, which will include 12 pairs of ribs anchored in the midline by the spine and anteriorly by your sternum. Your sternum would have three main components, right? Your manubrium, the sternum, and the xiphoid. Now, um, other bony components would be your scapula and your clavicle. And note that your airway is adjacent to a very important conduit for food and liquids, your esophagus. So the esophagus is posterior, behind your trachea. Now, your trachea is posterior to your heart, right? At least posterior to the important vessels going out of your heart. So, in addition to the important structures of the chest, there are important anatomic landmarks at the back, at the posterior chest that you need to be aware of, especially when it comes to auscultation. We have the auscultatory triangle, which is an area in the back which allows for better appreciation of the long sounds. It is defined, its borders are defined by your trapezius muscle, your latissimus dorsi, and your infraspinous fascia. The floor of your auscultatory triangle is your rhomboid major muscle. And beneath that is already your rib cage. And so, this relatively thinner portion of the posterior chest allows for better appreciation of lung sounds. Now, going back to this slide, this is provided for your review of the different anatomic structures found in the chest. So just bounce back so you can have a review instrument for your own benefit. All right. Now, another important concern in the anatomy of the chest would be the relative surface landmarks of the lung lobes. Note that the right lung has three lobes and the left lung has two lobes. On the posterior aspect, it's simpler in that majority, more than two-thirds of the posterior aspect of both the right and the left are corresponding to the inferior lobe of the right and the left lung. But on the anterior aspect, we have a middle lobe on the right lung, which corresponds to the inferior portion of the right um, lung field. Note that in the left lung field, since we don't have a middle lobe, almost the entire surface of the anterior left lung field will give sounds coming from the superior lobe of the left lung. So, note that there are particular areas on the chest that correspond to particular lobes of the lungs. And so, if you're going to listen, for example, to the middle lobe, then you will be listening to the inferior right lung field. And if you're going to listen to the right inferior lobe, then you are best listening onto the right posterior or the right base of the lung field. And so the other illustration in this slide show different surface anatomic landmarks relevant to situating yourself on the chest. These include your midclavicular lines on the right and on the left. You have your mid-sternal line, You have your mid axillary line, and you have your surface landmarks, which include your nipples at the T4 dermatome level and your umbilicus at the T10 dermatomal level. And so we move on to the next part, which is history taking with focus on chest pain, dyspnea, cough, and hemoptysis. So when we talk about chest pain, we need to explore the quality to differentiate the patient experience according to how we understand anatomy and physiology. Chest pain is often lumped together with dyspnea or difficulty breathing, which is why the key question is, kaya niyo po bang ituro kung saan yung pinakamasakit sa dibdib? Can you point with a finger where it is most uncomfortable? Now, there can be several answers based on your patient's experience. A clenched fist over the sternum or a non-specific generalized sensation on the chest suggests an evolving acute coronary syndrome, a cardiac pain that may be either angina or a myocardial infarct or something else that involves the heart. So that's a non-specific or generalized discomfort. Another possible answer would be the patient is able to pinpoint to a specific tender area on the chest wall. And this suggests musculoskeletal pain, which can be costochondritis, strained muscle, or perhaps even trauma. Now, if the patient gestures from the neck to the epigastrium in a corridor, no, that would involve, that may involve the center of the chest, that is strongly correlated with heartburn. Now, heartburn can be described as a burning, spicy, sharp sensation that arises from the abdomen, from the stomach, and from the epigastric area, and rising through the chest all the way up to the neck or to the throat. That is suggestive of heartburn. Now, so we have listed in this slide different components or different organs present in the chest and the causes of chest pain associated with each anatomic structure. The myocardium, if it is the source of the chest pain, can be due, this sensation can be due to angina, wherein you have impaired blood supply causing vasospasm and muscular spasm of the heart. Also, myocardial infarct, wherein you absolutely have um, blocked off blood supply to heart tissue. Now, I have said that the pericardium is not a sensitive or it's not thoroughly innervated with pain receptors, but it is it can cause sensation of restriction because it has stretch receptors. And that can be seen in the case of pericarditis or an inflammation of the sac surrounding the heart. You could also have dissecting aortic aneurysm. Not a very common phenomenon, but definitely a life threatening emergency. This can be due to certain connective tissue diseases, even syphilis. Now, the aorta, the dissecting aortic aneurysm would present with abdominal pain radiating to the chest. And this can be associated with really strong coughing or vomiting, or even it could be triggered by simply the urge to poo or straining when defecating. Uh, the other structure that can cause chest pain would be, of course, your large bore airways like your trachea and large bronchi. In the case of bronchitis, the parietal pleura, similar to the pericardium, is a tough, fibrous membrane, a tough, fibrous material, and similarly is not innervated with pain receptors but can perceive stretch. And so we see some chest pain or chest tightness along in pericarditis and pneumonia. Now, as I have mentioned briefly earlier, the chest wall. The chest wall is muscular and has also a cutaneous aspect. So, costochondritis, it could be musculoskeletal strain. It could be a portion of your intercostal muscles that have, been exerting too much or exerting too little, or it could be the result of prolonged bad posture, or perhaps lying down too much, or being seated in a bad way, like being stuck in a bus or driving in a bad position for too long. You could also have some herpes zoster presenting on the chest wall. Yeah, you may remember herpes zoster presenting as a dermatomal vesicular rash, initially presenting as a systemic viral illness, wherein it's very protean. The patient will have fever, will have malaise, will have weakness, will have definitely fever. And then a day or two, or perhaps even three after the fever, you after the start of fever, you see a cluster of vesicular rash with a dermatomal distribution on the chest. That is quite classic herpes zoster. Now, the esophagus is a structure that is commonly overlooked for chest pain, but is very, very common. In fact, I've seen this quite a lot during this pandemic period. A lot of people, of course, have been eating too much and not moving a lot. And this is a recipe for reflux disease. Reflux esophagitis um, can give you chest pain. It can also be quite vague in the sense that the patient feels like there's overall chest heaviness. The heaviness is all over the chest, and they feel it either before eating or after eating, and it gets worse at night. So those are some of the features of the history that you need to elicit to get an idea that the chest pain is not a cardiac emergency, but is something that you can manage with acid control. And so if you are entertaining chest pain, consider ruling out emergencies that will kill your patient sooner. These will include cardiac emergencies, vascular emergencies like aortic aneurysm, and of course, um, lung space occupying injuries like pneumothorax or um, hydrothorax or some other fluid occupying your lung space, therefore preventing effective air exchange. Now, it's not just structures in the chest that can give sensation of pain in the chest. You could also have the neck causing some chest pain. In the case of cervical arthritis, you could feel it some um, superior chest pain around the clavicle area. You could also have biliary colic causing referred pain to the shoulder or to the chest. And of course, in relation to reflux esophagitis, gastritis, because the stomach is connected to the esophagus and is in close relationship with the diaphragm. And of course, the vagus nerve. All of the structures, majority of the structures rather, present in the chest are innervated by your vagus nerve. And so understanding the path, the innervation of the vagus nerve is very important to differentiating the different causes of chest pain. All right, so we move on to the next concern in history taking, which is dyspnea. Now, dyspnea is a relatively complex symptom, but we need to understand the basic idea of breathing. So you have the drive of breathing coming from the midbrain, and this is influenced by receptors in your ganglia, which is also present in the midbrain, also present in your carotid and your major blood vessels. You also have mechanoreceptors in the chest, which assess the stretch, the extent of air expansion, and also blood pressure are also mechanoreceptors, baroreceptors. And you have metaboreceptors in your muscles, which tells Your brain, oh, we are accumulating too much carbon dioxide. Oh, we don't have enough oxygen. Either way, the brain is informed that there needs to be more oxygen coming in and more carbon dioxide needing to be released to the atmosphere. And so the brain, stimulated or informed by the receptors, instructs the ventilatory pump to increase respiratory effort or to decrease respiratory effort in response to the amount of oxygen and carbon dioxide in the body. So, some problem involving either the ventilatory pump or the chemoreceptors alone can already cause dyspnea. So, injuries to the brain, particularly involving the midbrain, traumatic head injury, can manifest with dyspnea. Injuries, of course, clearly to the chest wall will manifest with difficulty breathing. You could have some mismatch between the efferent and the reafferent branches of your nervous system. So, therefore, we see where the brain is telling the body that it needs to breathe more to bring in more oxygen. But in fact, the body has a problem processing oxygen in the tissues, which is seen in anxiety with hyperventilation. Usually, you see anxiety in young individuals, but there are cases of this happening in older individuals as well. And often it happens in situations after big news or events of significant emotional impact to the patient. And so the patient is triggered into fight or flight mode, and there is a sudden inrush of oxygen into the bloodstream. But this oxygen is not fully consumed, it's not converted into respiration, into cellular respiration. And so the patient manifests with jitters, with shaking, with tremors, and we see clear signs of agitation, increased respiratory rate, increased heart rate, dryness of the skin, the eyes are wide open. But when you listen to the lungs are clear, the air is moving quite fast, the breath sounds may be quite high pitched, but you don't see any obstruction, you don't hear obstruction, you don't hear rals or crackles. The patient otherwise, um, the patient has um, good oxygen levels around 99%, but the patient is having a difficult time breathing because the brain is telling the body, the ventilatory pump, to keep on breathing because the brain thinks there is not enough oxygen, or rather, more oxygen has to be supplied to the muscles, but the muscles are not burning enough oxygen. So, how do you solve anxiety and hyperventilation in relation to dyspnea? You find a way to increase carbon dioxide. You need to trigger a form of acidosis, of metabolic acidosis. And how do you do that? You have the patient breathe into a paper bag, a rebreather bag. That way, carbon dioxide is not lost immediately to the atmosphere, and more of it is retained in the lungs for the body to eventually use to, achieve optimal pH or optimal acidity, acid uh, blood gas balance. But then it's not just anxiety that is seen causing dyspnea. There are many conditions that can cause difficulty breathing, including asthma, COPD, cancer, or even edema, pulmonary edema. And so we need to differentiate the different aspects of difficulty breathing of dyspnea. There is chest tightness, paninikip ng dibdib. Parang it's the sensation of the chest is heavy and that you feel like the lungs are not expanding, or the lungs are not moving are not moving the same way they do. There is also that sensation of shortness of breath. Kapos sa hininga, yung the patient feels like there is air moving in but not enough. Like, okay, maiksi lang yung hininga. The breath effort is restricted or quite abrupt. Then there is also the quite difficult to observe phenomenon of air hunger. Air hunger, how do I describe it? This is seeing someone suffer from air hunger is a formative experience for me. Formative in the sense that you usually see air hunger in dying patients. Naghihingalo na sila. Kung nakakita kayo ng isda na buhay pa tapos kinuha nyo sa aquarium or kinuha nyo sa fish pond, and you just, watch the fish to die because you're going to cook it, that's how patients look like. Their mouth is like, they're, they're mouthing, they're trying to drink the air. It's terrible. It's terrible to see patients with air hunger. They're literally, well, not literally, but they're drowning. They feel like they're drowning, even though they're not in water, even though there is plenty of oxygen available to them. They feel like they're drowning. And so they're trying to force air into their lungs, acting as if they're wanting to drink it because they're just not feeling it. And then there's also that variety of dyspnea, which is increased breathing effort. Nakakapagod huminga. This is seen in patients with scoliosis, with asymmetry in the chest, in the rib cage, in the bony chest. Nakakapagod huminga. This can also be seen in patients with trauma to the chest because one side is not expanding as well. And usually this is associated with posture and is reflected in the uh, a change, reflected with a change in the shape of the chest. So chest tightness, paninikip ng dibdib, going back to the first one, is more associated with cardiac origins of difficulty breathing. Shortness of breath, now that one can be more specific for the ventilatory pump for the lungs and for the bony rib cage. Air hunger is more indicative of dyspnea coming from receptors in the brain or in the major blood vessels. The increased breathing effort, now that could either be due to the musculoskeletal receptors or also due to the ventilatory pump receptors telling the brain, oh, we're not getting enough oxygen or we're not expanding enough. All right, so that's for the dyspnea aspect of history taking. And moving on to the last part, which is cough. Very common in this time of the pandemic, and there are several variations to the cough. But we need to understand first that coughing is either voluntary or reflexive, meaning you can trigger yourself to cough, or it could also be purely reflexive. So, why do we cough? Because cough is a protective, mechanical action of the body. So what is coughing? Coughing is a rapid depressurization of the airways. Kumbaga, coughing is parang pinutok mo yung balloon, 'di ba? So parang meron kang balloon, tusukin mo, puk, ganun. Parang ganun yung pinaka-concept ng cough. There is a rapid discharge of air from a high pressure container to the atmosphere. Now, what is this high pressure container? This high pressure container are the airways in your chest, your lungs. And what holds the air in your lungs? It's your glottis. Your glottis shuts off the airway and having inhaled having inhaled an adequate volume of air to fill up the lungs, the muscles, that rib cage can start squeezing onto the lungs, generating a large pressure differential between the airways, between your lungs, and the atmosphere. And then it comes to the point that when your glottis opens, there is a large pressure difference, and so there's a quick movement of air from the high pressure container to the atmosphere. All along, since the trachea is also squeezed in by your lungs, no? The narrow trachea, the high pressure in the lungs, together, this creates a very high velocity, a very rapid flow rate through the major airways. The shearing forces, shearing as mabilis talaga, that develop in the process of coughing, it eliminates, it pushes out the mucus and the foreign materials out of the major airways, maybe perhaps into the esophagus wherein you swallow it, or out through the mouth wherein you spit it out. And because the shearing forces can be very strong, it can be also injurious. Coughing can also be self-injurious. Now, so there are two main components to your cough. You have the afferent, or the triggers, or the nerves that underserve the triggers of coughing. These are your trigeminal, your glossopharyngeal, superior laryngeal, and vagus nerves. Note that these nerves provide sensation to your nasopharynx, oropharynx, hypopharynx, and your larynx, and even some of your airways. And um, triggering these afferent branches of the cough reflex uh, can be due to exogenous or endogenous um, triggers. So some exogenous triggers include smoke, not just cigarette smoke, any smoke, um, barbecue smoke, um, construction, cement smoke, dust, fumes, foreign bodies more often seen in children that place toys with small movable parts into their mouth, accidentally inhaling them, or you could be that unfortunate adult who slurping down a bowl of soup, who is unlucky to have a small piece of corn get lodged into their airway after slurping it, or just eating soup. And there could also be endogenous triggers to cough, endogenous triggers of the afferent branches of the reflex. This could be due to postnasal drip, wherein you have mucus from your nasal cavity dripping down from the nasopharynx onto the oro and the hypopharynx, triggering the nerves, triggering the reflex. Or it could also be your gastroesophageal reflux, wherein you have acid ascending through the esophagus. The esophagus is irritated, the hypopharynx is irritated by the acid. The irritation causes the surrounding mucosa to produce plenty of sticky, chunky mucus that itself triggers the cough reflex, the chunky and the sticky mucus that the mucosa produces in response to acid. Um, and so when the reflex is triggered, the brain sends out instructions through the efferent branches to your recurrent laryngeal and spinal nerves that controls your ventilatory pump, and these nerves are coordinated to generate the high pressure container in your lungs, the container that the high pressure container that is created when you inhale uh, deeply and then shut off the airway by closing the glottis. And so that is that high pressure bag uh, is mediated by your recurrent laryngeal and spinal nerves. Your recurrent laryngeal specifically um, innervating your glottis. Now, an important concern with regards to cough is finding out how long have you been coughing. Have you been on coughing for a few days, acute in that sense, subacute for more than 2 weeks, maybe? Or is it chronic, more than 3 weeks, more? So, well, in the Philippines, chronic cough, consider TB. Cliche maybe, but it's true. Although we do have some important achievements with regards to TB treatment and the diagnosis of TB, it still is out there. So also ask for other aspects of the coughing. Is it seasonal or is it associated with wheezing? In which case, it could be allergic. Your triggers could be allergic in nature. Is the cough associated with fever or with sputum? In which case, oh, it's probably infectious. Could be bacterial. Now, in this pandemic, we know that COVID-19 is caused by SARS-CoV-2 virus. It's a virus. And by default, most viral lung infections can be self-limited and are not treated um, specifically by antibiotics, by antibacterials. But many physicians, myself included, have done prophylactic prescription, especially in during this pandemic. What is my basis or our basis for prescribing this? It is observed that in majority of cases with viral pneumonia, as a bacterial superinfection sets in, and so certain prophylactics, medical antibiotic prophylactics are indicated to prevent bacterial superinfection of the lungs. Um, is this standard practice? I don't think so. But many doctors are doing this to be more preventive and be more aggressive in protecting their patients against pneumonia, because that is how you will have patients die if the viral infection has a secondary bacterial infection. The viral infection will limit itself, but the bacterial infection, that one will need antibiotics. Anyway, so cough can also be due to infections. Now, as I've said earlier, coughing is a vigorous process that can generate shearing forces sufficient to cause injury to the airways. And so, when the airway is injured, there could be ruptured vessels, and that can present as hemoptysis with blood, tinges of blood on the sputum. And where could the blood be coming from? It could be coming from the airway, yun nga, as I've described with vigorous coughing. The cough is abrading the airway, the mucosa of the airway. It could also be due to the nasopharynx. During sneezing, the shearing forces are channeled through the nose. And so the same forces can cause the nasal mucosa to have some ruptured membrane, some broken blood vessels, and these can bleed. Now, hemoptysis can also come from the GI tract, um, also due to coughing, since a part of the esophagus or the hypopharynx rather can be injured. It could also be due to irritation from acid in the case of reflux. It could also be due to cirrhosis or some form of liver disease that causes accumulation of blood in venous structures surrounding the esophagus, esophageal varices. Now, esophageal varices can have very thin walls, and coughing or even a Valsalva maneuver, an increased intra-abdominal pressure, can cause some of these varices to rupture and bleed. And these bleeding varices can manifest as hemoptysis. An important consideration when checking for hemoptysis is if there is also bleeding from through the os or with bowel movements, because you need to assess if the hemoptysis or the bleeding is massive. How much blood is the patient losing? More than 100 or 600 ml over 24 hours would urge you to be more aggressive in managing the patient, meaning go for imaging, go for endoscopy, go for surgery if there are indications. All right. And so we move on to the third part, which is the physical examination of the chest and the techniques involved. The sequence in the physical examination of the chest is as follows. First, inspection, followed by palpation, percussion, and finally auscultation. Note that this is the same sequence done when you are examining the anterior chest. An important difference will be the position, the posture of your patient. In examining the posterior chest, the patient has to be seated upright. You may ask the patient to cross their arms with their hands on opposite shoulders, hands across the chest, and have them hunch over a bit. My recipe would be, ma'am, sir, pwede pong ilagay ang kamay sa magkabilang balikat at yumuko po kayo. So, in that particular position, you are actually expanding, exposing the auscultatory window. And that allows you better appreciation of the posterior chest. And so, this particular sequence of the posterior of the examination of the posterior chest is also carried over to the anterior chest, but the anterior chest position examination of the anterior chest is done best when the patient is lying down or reclined at an angle. So that's an important consideration. Patient is seated for posterior chest examination, lying down or reclined when you are examining the anterior chest. Moving on to inspection. The very important part of inspection is the initial survey. What do you do with the initial survey? You observe the patient without any prior instruction. Just ask the patient to breathe as they are. Note the rate, the rhythm, the depth, and the effort of breathing. It would be best if you can have the patient disrobe so you can see the chest fully exposed and see if there are retractions, if there are asymmetries in the movement or the expansion of the chest without you touching, without you instructing the patient to do any maneuver, any position. The normal respiratory rate varies. Some sources would say it's 12 to 16, but for our purposes, it's 12 to 20 cycles per minute. Look for signs of anemia. These can be seen as cyanosis, a dusky, a darkening coloration of the mucosa or the skin below the tongue, on the palms, or on the feet. You could also see signs of chronic insufficiency of blood, as for example, in clubbing, finger clubbing. When you assess for clubbing, you can put two forefingers together, nail to nail. You should be able to see a gap between the nail beds. That's called Shamroth's window. The presence of Shamroth's window tells you that, okay, there is no clubbing. But for individuals with clubbing, the Shamroth's window is absent. And there is a prominent um, enlargement of the fingertip, which suggests that there is significant peripheral vascular growth at the end of the fingers because the tips of the fingers are chronically hypoxic. They are chronically starved of oxygen. And so, in compensation, the tissues at the end of the fingers produce stimuli to create more blood vessels. Thus, the fingertips are larger than the rest of the fingers, thus clubbing. One maneuver that you can ask the patient to do would be to walk or climb a flight of stairs. Now, this is with careful consideration because patients coming for your assessment of the chest may already have prior difficulties, and this may be additional stress that is no longer possible for your patient. But then, this can be done especially to differentiate types of dyspnea and to assess the capacity of your patient. Note if the patient is able to speak in full sentences before catching their breath. This will also help you differentiate if your dyspnea or your chest pain is coming from a particular component of the of the a particular portion of anatomy. So, for example, patients barely able to speak would have probably um, a problem in the central receptors, since the brain and the chemoreceptors are overriding the ventilatory pump and keeps telling the ventilatory pump, inhale, 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 and that makes speaking very difficult. They are telling the ventilatory pump to inhale because the chemoreceptors are not getting enough oxygen. They are being stimulated by excess carbon dioxide. Now, as well as looking at the patient uh, as part of the initial survey, you also listen to their breathing, even without a stethoscope. If you hear audible wheezing or stridor, that could be the clue that you are looking for to clinch a diagnosis. Look at the neck as well. Note if the trachea is midline. Now, tracheal deviations are very telling. More often than not, they are emergencies. Could it be pneumothorax? There is air in the chest cavity that deviates the lung and pushes the trachea onto one side. That's an emergency. You will need to release that air sooner rather than later. Are there supraclavicular retractions? Which means there is significant difficulty in the breathing of your patient. Are accessory muscles used? Usually, when the patient is calm and breathing normally, you only involve the diaphragm and the intercostal muscles to change the size and the shape of the chest cavity. But if you already recruit uh, the trapezius, the sternocleidomastoids, and even other neck muscles, then that tells you there is difficulty breathing. And then, of course, observe the chest wall. Note for the shape and the symmetry of movement, and note any masses, sinus tracts, or rashes on the chest wall. In this particular series of illustrations from Fokin, note that there are different varieties of chest wall deformities. On the left most side, we see a normal chest, followed by an example of pectus excavatum, wherein there a concavity in the middle around the breastbone. You have pectus carinatum, wherein the breastbone is anteriorly projected, causing a pigeon breast deformity. A variety of the pigeon breast deformities, the pouter, pouter, puter, pigeon breast, wherein the anterior projection of the breastbone is only on the superior half of the breastbone. And then you also have Poland syndrome, wherein you have other deformities as well, including the hands and the incomplete formation of your rib cage, particularly the cartilaginous aspects your um of your ribs in connection to your sternum. And then you have a cleft sternum, which can be associated with other cardiac defects. And so we move on to palpation. Now, the most important thing, or rather the first thing that you should ask in palpating the chest is ask if there are any tender areas. You do not start with these and you minimize contact with these tender areas. So, with that out of the way, there are several points that you need to be aware of in palpating the chest. You have to maintain some symmetry in palpating the chest. You must compare the left to the right, the lateral to the medial, the superior to the inferior, the base to the apex. Now, comparing the symmetry of palpation, um, in particular for tactile fremitae, will help you assess for the consistency of the lung tissue. Now, the technique for feeling tactile fremitae um, involves having the patient say an important keyword. It's for English speakers, it could be 99, but for Filipinos, it could be easier to say tres, tres. Now, in using those keywords, you are creating vibrations. The speaker is creating vibrations that will be transmitted from the airways, through the airways, and to the chest wall. Now, as the examiner, how do you feel for these vibrations? You use the balls of the hand or the palmar aspect of your metacarpophalangeal joints, or you can use the ulnar surface, which is the palmar aspect of the fifth finger, the fifth metacarpal. All right. And so you have a series of locations wherein you ask the patient to speak. Okay, ma'am, sir, tuwing ilalapat ko po ang kamay ko sa likod nyo, sabihin nyo po, tres, tres. Okay, ma'am, tres, tres po, tres, tres. Move on to the next, tres, tres. Next, tres, tres. Next, tres, tres. So, that's just one script I use in telling my patients what to do as I do as I do assessment of tactile fremitae. Now, tactile fremitae can be decreased or absent when the voice is soft or when the transmission of vibrations is impeded. What can cause impeding what can impede the transmission of vibrations? These can include obstruction of the bronchus, COPD, separation of the pleural surfaces by fluid in the case of pleural effusion, or fibrosis in the case of pleural thickening, or air in the case of pneumothorax. It could also be solid in the case of an infiltrating tumor. Or in certain individuals who may probably be, more physically active, just having a very thick chest wall, muscles, thickly muscled individuals could, prove tricky to assess for tactile fremitae. Now, the other technique of palpation is to assess for symmetric chest expansion. How do you do this? So, with both hands, imagine you can stretch both hands out in front of you. All right. Try to form a diamond with both hands. Thumb tip to thumb tip, forefinger tip to forefinger tip. Okay. Imagine that in front of you. Separate them and imagine placing them on the 10th rib level of the patient's chest, the posterior chest. Now, squeeze together a bit the thumbs, pull together the thumbs a bit. So imagine the skin on the back of the patient is being bunched up slightly together. Now, ask the patient to inhale. Now, as the patient inhales, note the change in distance between your thumbs. That will tell you the symmetry of the chest expansion. Of course, the important reference here is the spine. Note that before you ask the patient to inhale, the thumb tips must be equidistant from the spine. And so as you assess the excursion of your thumbs from its initial position, that will tell you the symmetry. If both thumbs travel further away from the midline from the spine with equal distances, then you have symmetric chest expansion. Now, these are the sites wherein you can assess for tactile fremitae. So there are four pairs. So ask the patient to say 99 or tres. Oh, ma'am, sir, good morning. Every time I place my hands on your back, please say 99. All right, let's begin. I place my hands here, 99. Again, number 2, 99. Number 3, 99. Number 4, 99. All right, so now we're done with assessment of tactile fremiti. The same technique can be used in assessing the anterior chest. Note that there are fewer sites on the anterior chest compared to the posterior chest. And so we move on to the technique of percussion. Percussion is very important in the examination of the chest and abdomen. The goal of percussion is to create audible vibrations through the body. There are two main components: the pleximeter, which is the finger applied directly onto the skin of the area to be assessed, and the plexor, the one striking the pleximeter. Now, what is a good analogy for this? It's the drum, in fact. The pleximeter creates the drum by stretching the skin. So the patient's skin becomes a drum with the pleximeter pressed on it, and your plexor becomes the drumstick that you strike the drum with. So, to create the sound that will be helpful in assessing the consistency, the quality of the lung tissue beneath, you need to give some time after each stroke. You will see in many videos the examiner doing something like this. Now, what I say is, you are not a woodpecker. I have also seen videos that is a bit more vigorous, wherein the examiner doing something like this. So I find that problematic because you do not allow the resonance to happen. You are not giving enough time to listen. So what do I suggest? Strike once and strike well. Listen. Listen after every stroke. Allow a period after striking to listen. Avoid becoming a woodpecker. What could be another tip that will improve your percussion technique? It would be to press firmly with the pleximeter to stretch the skin. Stretching the skin will optimize the transmission of the strike force to the tissues. When you have a drum, or to the drummers among you, you will know, that the drum skin has to be stretched very well. It has to be taut. It has to be very tightly stretched for a sound, for the strike to be converted into the audible vibration. Now, if the drum is not stretched appropriately, you will not be able to hear the sound that you want to make, or you will not be able to make the sound at all. And you do that by applying the pleximeter firmly onto the skin, firmly but without causing pain. So that is something that you will need to learn with consistent practice. How to apply your pleximeter firmly but without causing pain. What can help with that? What can help in applying firmly without causing pain, as well as making sure that you don't hurt yourself while doing percussion, is to cut your nails. Cut your nails. You are going to strike your pleximeter finger with your plexor right onto the distal interphalangeal joint. Now, how do you strike that? You strike that with your fingertip, and your fingertip is protected by a nail. Cutting your nails to a safe length and making sure that it is not too sharp will make your percussion technique more effective. Otherwise, you will hold back from striking your finger because it's too painful to strike, or you may already have caused wounds onto your finger. how can you percuss when your fingers are wounded, right? Anyway, so what do? You prepare beforehand. If you know that you're going to do percussion, cut your nails beforehand. Use a buffer to make sure that the nail edges are not sharp. Newly cut fingernails are sharp. So, what could be some technique that can help blunt the sharp nail edge? If you are like me, who has corns and calluses on your feet, you can scratch using your newly cut fingernails the corn or the callus. It will soften the nail edge, I assure you. But of course, make sure that you wash your hands afterwards. All right? Make sure that your hands are clean before you proceed with the physical examination. Unless you have a buffer, which is a more practical and more um, standard way of making sure that your nail edges are not sharp. Well, we make do with what we have, but make sure that nail edges are not sharp when you do percussion. And finally, one tip that can help your percussion technique is to use one finger as a pleximeter, avoiding contact with other fingers of the hand that you're using as pleximeter to make sure that you are not by accident dampening or absorbing the vibrations that you are generating. Applying several fingers onto the tissue adjacent to your pleximeter will will absorb the strike, the vibration generated by your plexor. And so make sure that you're only touching the skin surface with one finger, with only the pleximeter finger, so that the vibrations will be more will be channeled more onto the tissues and are not absorbed by your other fingers. All right. So with sufficient effort on striking the pleximeter finger, you should be able to appreciate the different tones or different sounds of percussion, of which there are mainly five. There can be flatness, dullness, resonance, hyperresonance, and timpani. The normal lung is resonant. The normal lung is resonant. But if the lung is hyperinflated, like in the case of COPD or asthma, you could see hyperresonance. Now, um, what could be some aspects of the body that is dull on percussion? The liver, solid organs can be dull on percussion, or rather, are dull on percussion. So the lung, the spleen on the left aspect of the abdomen, the over the precordium, the heart can be dull. Another sound that you can appreciate with percussion would be flatness. And this would be with relatively um, um, soft and mobile tissues like muscles or fat, as can be seen in the thigh. And then you have timpani, that you hear more with air filled or fluid filled structures. A drum stroke is tympanitic. An abdomen filled with gas is tympanitic. The stomach filled with air is tympanitic. A cheek full of air is tympanitic. So those are some of the sounds that you can generate with percussion: flatness, dullness, resonance, hyperresonance, and timpani. So what could be some causes of the lung being dull? Dull lung tissue can mean lobar pneumonia, in which the alveoli are filled with blood and pus. It could be pleural accumulations of serous fluid, like in the case of pleural effusion, or blood in the case of hemothorax, or pus in the case of empyema. It could also be a tumor or fibrous tissue, scar tissue. So those are some of the reasons why the lung would lose its resonance on percussion. So as with palpation, symmetry and a systematic approach to getting the sound uh, of percussion is important. Note that there is a ladder pattern for percussion and auscultation. This is a recommended approach, but the key point here is you are able to listen comprehensively to the different areas of the lungs, both superior lobes, both inferior lobes, and the middle lobe as well on the right lung, and that you are able to differentiate the sound made by the lung bases from the apex. Percussion is also an important technique in assessing the level of the diaphragm. Note that superior to the diaphragm, you will hear resonance because you're listening to the lungs. But below the diaphragm, you will hear dullness. Particularly on the right, you will hear dullness due to the liver. But on the left, you may be able to hear some tympany because you have shifted from the lung onto the stomach, which may be filled with gas or air. Now, to assess the descent of the diaphragm, first you need to measure the level of the diaphragm with the patient normally breathing. So have the patient hold their breath for a while and measure the level of the diaphragm. And then have the patient fully inhale and again measure the level of the diaphragm. Normally, with fully inflated lungs, the diaphragm can descend anywhere from 3 to 5 centimeters. But this degree of descent can vary, especially with highly trained athletic individuals who have diaphragms move as much as 8 centimeters. So, the systematic approach to percussion, wherein you have good exploration of all lung surfaces, is also applicable to the anterior chest and the technique of auscultation. So, the areas that you percuss are also the areas that you auscultate. And note there is symmetry that has to be observed. You compare the right to the left, the superior to the anterior, the medial to the lateral, the base to the apex. And so the systematic approach to palpation, percussion, and auscultation will help you assess more comprehensively the different portions of the lungs. Make sure that you are assessing all lung lobes. Auscultation is a very important technique in assessing the lungs, and it is done using a stethoscope's diaphragm. Now, the diaphragm has to be applied onto the skin directly and advise the patient to breathe with an open mouth because the patient may be generating some sounds through the nose or through the throat if the mouth is closed. As I've described earlier, auscultation is best done when the patient assumes a particular position, which is with the hands crossed over the chest, hands on the opposite shoulders, and hunched over a bit. This opens the auscultatory window on the posterior chest. Important technique: listen for one full breath at each location. It's not exactly a matter of time, but it's more a matter of a full cycle at each location. You have to note the duration, the intensity, the pitch, and the location of the sounds. So, what are some sounds that you will encounter in auscultation? There are normal breath sounds, adventitious sounds that are associated with disease, and transmitted voice sounds like bronchophony, egophony, and whispered pectoriloquy. Let's park normal and adventitious sounds later, and let's look at transmitted voice sounds first. To assess for bronchophony and whispered pectoriloquy, you can have the patient say and then whisper 99 or tres tres. For bronchophony, you have the patient speak And then for whispered pectoriloquy, you have the patient whisper. Note that for both, you use a stethoscope. So, you apply the stethoscope onto your selected area and have the patient say, okay, ma'am, sir, kaya niyo pong sabihin, stress, stress. Okay. When the patient says stress, stress, and you hear it louder through, louder and clearer through the chest wall, then that tells you there is some bronchophony happening. There is bronchophony. And what does this tell you? Because sounds are better transmitted by solids and liquids, there is some consolidation or some fluid buildup in that area of the lung. Bronchophony, louder, clearer voice sounds. Whispered pectoriloquy, louder, clearer whispered sounds. So instead of speaking tres tres, you ask the patient to whisper in whispered pectoriloquy. Egophony, there is a change from an E sound to an A sound that you hear when you listen to the chest. So, bronchophony, have the patient say tres tres or 99. Whispered pectoriloquy, you have the patient whisper 99 or tres tres. And then for egophony, you have the patient say E. And in all of those, you use a stethoscope to listen. And so in this table, we explore the different normal breath sounds. You have vesicular breath sounds, bronchovesicular breath sounds, bronchial breath sounds, and tracheal breath sounds. The tracheal and the bronchial breath sounds are best appreciated with the larger bore airways. So more central, more superior over the trachea in the neck for tracheal and over the manubrium for bronchial air sounds. Now, the lung tissue, the parenchyma, are mainly vesicular and bronchovesicular. So they are more described by their um, timing, the inspiratory, lasting longer than expiratory for vesicular, and they're relatively quiet. You can probably listen to these sounds on yourself, using a stethoscope to listen to your own chest. Now, these are some of the breath sounds, adventitious breath sounds that you will encounter. These include crackles or rals, and wheezes or ronchi. Wheezes and ronchi. Now, crackles are intermittent, non-musical, and brief, like dots in time, discontinuous. What could be causing crackles? Crackles are due to your alveoli popping open as air enters it. Why would your alveoli pop open? It's because the mucus is quite sticky and the alveoli are not easily expanding, are not quietly expanding as it is filled with air. And so it is more an abrupt opening of the alveoli that is happening because of stickier phlegm, because of parenchymal inflammation, of infection. And this popping open of the alveoli can be heard as crackles. It could also be coarse crackles, especially if finer airways are suddenly popping open as well uh, from a previous collapsed state due to stickier phlegm or due to inflammation. Now, wheezes and rhonchi are vibrations of the airway. What could cause vibrations of the airway? Um, a narrowing of the airway, a thickening of the airway as seen in asthma or in COPD, a change in the elasticity or the consistency of the airway will make the walls vibrate at a particular frequency. Um, In asthma, we associate wheezes more, but wheezes can also be heard in COPD and also in some forms of pneumonia, depending on the type of the pathogen. But wheezing is more of a vibration of the airway because of narrowing or a thickening of the airway. Rhonchi can be due to vibrations of the airway because of fluid accumulation. You could imagine rhonchi to be sipping shake through a straw. You may be sipping like I don't know, a sludgy chocolate milkshake, and that is the sound of ronkai. I'm sorry for making that sound, but that is how some ronkai will sound, or rather, that is the mechanics by how ronkai are generated in your lungs. So it's more of the mucus, the phlegm, cellular debris, making the lung fluid a bit more sticky, a bit more sluggish. And as you inhale or exhale, the vibration caused by the sludgy fluid makes the ronchi. So that is some of the auscultation findings you will encounter in a pathologic case. And finally, for the last part of the examination of the anterior chest, note that the same sequence is observed, but there are a few key differences. For inspection, have the patient in a supine position. As for palpation, fremitae are usually absent in the precordium because clearly you have the heart in that position. In percussing the anterior chest, you can percuss for the upper border of the liver. And if you're going to do the same way for the inferior border of the liver, you can assess the liver span. But assessing the liver span is already part of another um, portion of the body. That's assessing part of the abdomen. But anyway, assessing the upper border of the liver can be part of the chest examination. And finally, auscultation, especially for female patients, you can request your female patients to kindly displace their breasts to one side or the other as necessary for you to properly listen to their lungs. All right, so that's the walkthrough of the history taking and physical examination of the chest. So we've walked through some of the anatomy and physiology, including some symptoms of uh, of the chest, like chest pain, dyspnea, cough, and hemoptysis, as well as the techniques of palpation, percussion, and auscultation. Now, the goal, as we have mentioned in the beginning, is for you to create, for you to develop the skill to report chest findings like this. Thorax is symmetric with good expansion, lungs resonant, breath sounds vesicular, no rales, wheezes, or rhonchi. Diaphragms descend 4 centimeters bilaterally. Or it could be for a pathologic patient like this. Thorax symmetric with moderate kyphosis and increased anteroposterior diameter, decreased expansion, lungs are hyperresonant, breath sounds delayed, distant with delayed expiratory phase, and scattered expiratory wheezes. Fremitus decreased, no bronchophony, egophony, or whispered pectoriloquy. Diaphragms descend 2 centimeters bilaterally. Now, Bates is a very good reference and has more extensive discussion of the different techniques and how different findings indicate different disease processes. I would also recommend at this point, if you have the time and the energy, to start opening Harrison's Principles of Internal Medicine. At least the first few chapters, the first 200 to 300 pages, they have Harrison's. It's a good discussion of the symptoms of cough, chest pain, dyspnea, and hemoptysis, as well as edema in relation to lung function. And those are good approaches to understanding how history taking and physical examination will proceed. And so, That's the end of my lecture on history taking and physical examination of the chest. Thank you very much.